All right, ladies and gentlemen, could we have a seat, organize yourselves, get comfortable. By the way, I should note that we do have an overflow room if you want some space. Down the hall, there's an overflow room. Feel free to use that. The slides and everything are going to be projected there. There's also a restroom right across the hall. If you need some space over there as well, please help yourself. I'd like to welcome the three work groups that we've been working pretty intensely with over the past year plus, and appreciate you being here. Also appreciate the folks interested in this topic on the webinar. Just so you know, in the room we're expecting about 15 or 20 work group members. There's public here as well, and some other folks who want to make comments, other stakeholders, providers, and so forth. We welcome you all, and thank you for your interest. A couple housekeeping measures. First of all, as I mentioned, this is a webinar, so please, if you have a question or you're making comments or whatever, please either use the microphones for the panels. They'll be using the microphones up here. There's a microphone here. There are microphones in the room, as you could see from the ceilings. So if you have a question, please speak clearly and loudly so that it could be caught by the microphones. Also, for the work group members that are here in the room, we do have parking vouchers for you. So someone will be going around during the course of the meeting to hand out those vouchers that you can use at the grand parking, I believe, across the street here, assuming you're in that garage, and that's where the instructions to park there. With that, I'd like to go around the room just for the work group members, and then we're going to open up in a minute, Greg, I think the webinar so the work group members that are on the webinar can also introduce themselves, just so we know who is in the room and who's on the webinar. So let's start with Barry.
Sure. Barry Rosen. I'm an attorney at Gordon Feinblatt.
Orly Panich, an emergency physician with MEP.
I'm Mike Robbins with the Maryland Hospital Association.
Shure Tilakova, HSCRC.
John Intner, Calvert Health System.
Barbara Brocado, Brocado and Associates.
And be interested to know from the folks on the webinar whether you could hear their announcements clearly, so you can send a message to Greg letting us know. So now we're going to open up the webinar for just, again, the work group members, and to do it in a somewhat organized fashion, I'll ask for by work group. Is it open, Greg?
Yes.
For the work group members?
Members.
Okay. So, okay. Well, let's see if we can hear from any of the work group members through let's try first the performance measurement work group. Could anyone who's on the webinar from the performance measurement group just let us know? Oh, okay. Tell you what, we don't want to waste any more time on this. We do have a list, and we'll have a list later on that we can provide to everyone who participated via webinar for that purpose. So, okay, Dr. Zumel is on the line. Okay.
Albert Blumberg's on the line.
Okay, good.
Ben Lowenschritt.
Okay. Anyone else? I know we have more. Again, we'll report that back to you. This is a slightly different meeting that you are used to from the past, and you can tell that from the agenda. This is not, we don't have a particular topic that we're going to be, necessarily presenting recommendations to the Commission on. This is more of kind of a briefing that was encouraged through some legislation last year. You may recall during the legislative session last year, the Commission came in with some legislation to clarify the Commission's authority and to ensure that the Commission has the tools it needs to be able to manage under the new all-payer model, and also clarifies, that how Commission sets rates in terms of not just unit rates, but clarifies that we're also going to be working toward global budgeting. An amendment was added to that bill that said that the appropriate Commission work group or work groups should consider the impact and implications that defensive medicine, the cost of defensive medicine, has on hospital costs and the goals of the new all-payer model. In response to that, we reached out to some experts, some folks in the field to help us do a report, do research, do literature search, to kind of put together the lay of the land today. What is the lay of the land in cost of defensive medicine, and how, in essence, really it applies to Maryland. Many of the studies are national. So how this may apply to Maryland and how Maryland may be different given the all-payer model and some of the reforms that have already taken place. Now, we struggled when we first started about deciding which work group we would put this in. We thought, well, payment models makes a lot of sense. These are costs in the system, could relate to global budgeting. Definitely, we need to have the payment work group. Well, wait a minute, performance measurement, this could be a potentially avoidable utilization if we can find cost savings in the system. So we got to have performance measurement too. And then, of course, the folks in the physician alignment engagement group think this is very important. So we thought it was very important to include them to ensure that on these topics that physicians and hospitals at least understand the issue and are aligned toward trying to resolve some of the issue and the cost. So we invited all three. The agenda today is in two parts. One, we're going to have a presentation of the report, the research that we talked about, and in order to, and that will take about an hour with some questions. The second part of this is we'll have several panels and others who wish to make some comments in the last hour. We're going to limit the time to 4 minutes per person for that. And I would ask that anyone who wishes to make comments to sign up. There's a sign-up sheet over here. And at the end of that, we will open up the webinar so that folks could also make comments from the web. I want to emphasize this is not a hearing on tort reform. You have that opportunity once or twice or 3 times every year in Annapolis. We have a singular focus is to look at what really is the lay of the land today, not what it should be, not where we should go, but what is it today and how it impacts cost and how Maryland may be different than others and how this what implications that may have for our new all-payer model. So just as you're making your comments, if you could help keep that in mind, it'll be very helpful. What is the outcome of this? We will be reporting to the Commission from the report and the comments, the discussion that we have today, just so as they are making decisions and as these work groups are making decisions, to keep these topics in mind so that as they're making payment decisions and potentially avoidable utilization decisions, that these can be in mind. With that, are there any questions at this point about the meeting today and what the organization is, what we're trying to achieve? Okay, with that, let me start with introductions. We thought it would, when we looked at this language, we thought it would be appropriate to bring together an objective team who have expertise and knowledge in both tort law, in the Maryland system, and also in economics. So we're really very fortunate to find that right in our backyard. And so we communicated with Diane Hoffman and Dr. Herring. Diane Hoffman will start the presentation. Diane is a professor of law and the director of law and health program at the University of Maryland Carey School of Law. That's why we're here today, and thank the Carey School of Law for the accommodations and the comfortable room. Also, and secondly, will be Dr. Bradley Herring, who is an associate professor of health economics in the Department of Health Policy and Management. So with that, I will invite Diane to come up and start the presentation.
Thank you, Steve, and good morning, everyone. It's really actually a pleasure to see some faces that I haven't seen for a while. So as Steve said, this project began with the passage of House Bill 298 during the last session of the Maryland General Assembly, and we entered into an MOU with the Commission to look at the issue of defensive medicine in late November with a start date of December 1st. And I mention that only because this project had a relatively quick turnaround. So under the MOU, we agreed to give this presentation and to prepare a report that would include a summary of the literature on defensive medicine, including national, state, and local studies or reports prepared by government agencies and objective peer-reviewed studies. Also to look at any other relevant data that might be from Maryland that we could find. And specifically, we were asked to determine the extent to which health care with a focus on hospital costs are related to defensive medicine, the extent to which tort reform impacts hospital costs related to defensive medicine, the service lines that incur higher or lower defensive medicine costs, and how defensive medicine may or may not impact the growth in the cost and quality of hospital care in Maryland, and implications for the Commission's ability to manage cost growth under the new all-payer model. In terms of the presentation this morning, I'll be talking about some of the background of defensive medicine, why it's controversial, and the approach we took to studying it. I'll then move on to discuss the 1994 Office of Technology Assessments report, which is the foundation document for research that was done prior to 1994 on defensive medicine, and we think does a good job of actually explaining a lot of the issues that make this such a hard topic to get a handle on. I'll then turn the podium over to Brad Herring, who will talk about the studies that have been conducted since 1994 and what we can conclude from those studies. I'll then talk about some of the different factors that affect the practice of defensive medicine and defensive medicine in some specialty areas, most specifically obstetrics, and then we'll conclude by talking about the implication of our findings for Maryland. I think it's fair to say that there's a general agreement that the practice of defensive medicine does exist, but the difficult issue is determining to what extent it exists. Large part, this seems to be due to the context in which many discussions of defensive medicine takes place, and that's tort reform. And tort reform, as you know, is a highly contentious issue with various stakeholders having strong views as to whether states or the federal government should implement such reforms. One of the arguments that's in the tort reform debate is the frequency and severity, is whether the frequency and severity of malpractice claims motivate physicians to practice defensive medicine and how much it does. So depending on one's view of tort reform, that may influence studies about defensive medicine. The different stakeholders in that debate often prepare reports or have consultants prepare reports that look at the impact of tort reform on defensive medicine. And as a result, we see some widely ranging estimates of the amount of healthcare spending attributable to defensive medicine. So when looking at the literature, I think one has to be quite cautious in looking at who did the study and why, and so therefore the approach we took was to limit ourselves pretty much to reports by government agencies and peer-reviewed articles in recognized academic journals. We also tried, and we screened out potentially biased studies and studies that were poorly designed and unlikely to yield generalizable or reliable results. We also tried to find some Maryland-specific data, and for that looked to the Maryland Healthcare Alternative Dispute Resolution Office and the National Practitioner Data Bank. And we also spoke to a few of the hospital physician insurers in the state. In terms of our literature review, we started out looking, as I said, at the 1994 OTA report for the early literature on defensive medicine. OTA, the Office of Technology Assessment, for those of you who aren't familiar with it, was established to provide members of Congress and congressional committees with objective and authoritative analyses of the complex scientific and technical issues which were facing society, which also Congress was being asked to consider. The 1994 report entitled Defensive Medicine and Medical Malpractice was prepared in response to a request by the House Committee on Ways and Means and the then Senate Committee on Labor and Human Resources. Before delving into the literature on defensive medicine, I think it's important to understand how defensive medicine is defined in the various studies, and the problem is that it's defined differently in the different studies. So I think one of the most common definitions that's referred to in the literature is the OTA definition, which says that defensive medicine occurs when doctors order tests, procedures, or visits, or avoid certain high-risk patients or procedures, primarily but not necessarily solely because of concern about malpractice liability. The definition includes both positive defensive medicine, also referred to as assurance behavior, and negative defensive medicine, referred to as avoidance behavior. Assurance behavior includes things that supplement traditional medical practice, things like additional testing, hospitalization, referral to specialists. And avoidance behavior includes actually refusing to treat certain patients or refusing to perform certain risky practices. There are a number of definitional issues with defensive medicine. Those include whether the defensive medicine practice is conscious or unconscious, whether it's the primary or sole motivation of the practice, whether it includes only practices that are harmful or of no benefit, or also includes practices that actually have minor or marginal benefit. Unconscious practice of defensive medicine are practices that might have originally started out to be done because they were defensive, they were done to protect the physician from liability, but then they become, over time, so ingrained and incorporated in medical practice that they become unconscious, and no longer, people may no longer be aware that they're doing the original motivation with defensive medicine. The OTA report includes practices that are primarily but not solely done out of concern for liability. This is in part because, at least they found in studies, physicians are reluctant to say that they do something solely because of fear of liability. Usually the physician believes it will offer some benefit, even if it might be very small to the patient, which goes to the third definitional issue, which is whether the definition includes procedures that have any benefit. So this chart kind of shows you the range of things that might be considered within defensive medicine in the literature. So on the far end, the harm to the patient and no benefit to the patient are, generally included in all the literature, but then it becomes more of a gray zone in terms of where the boundary is when we get to some benefit and how much benefit would that be. And an issue is that a lot of the studies don't actually define it. They will ask physicians, do you practice defensive medicine? And so it's left to the physician's subjective judgment as to whether they are doing this as a matter of protection from liability. In addition to looking at the definition of defensive medicine, the OTA report set out to answer these questions. What are the causes of defensive medicine? How widespread is defensive medicine today? What effect will current proposals for malpractice reform have on the practice of defensive medicine? What are the implications of other non-malpractice aspects of healthcare reform for the practice of defensive medicine? In doing so, the report authors reviewed the prior studies, pretty much all of the ones that they could find. These prior studies generally adopted one of these three methodological approaches to measuring cost and impact of defensive medicine. The first are direct physician surveys. These surveys ask questions such as, does fear of threat of malpractice liability influence whether you use additional diagnostic or therapeutic procedures, or how often do you practice defensive medicine? The second type of survey that's done are giving physicians clinical scenarios and asking them to choose specified clinical actions and then ask them what influenced their choices. To check off, you'll give them things like, clinical reasons, patient demands, or usually, malpractice concerns will be one of the choices. The third approach is statistical or econometric analyses of the impact of malpractice liability risk on utilization of one or more procedures. It could be C-sections, it could be CAT scans, it could be biopsies, and other things. And malpractice risk was typically measured in these studies by things like malpractice premiums, prior lawsuits, tort reforms such as caps on damages. The authors of the OTA report found that each of these methods, though, had some significant shortcomings. So both direct physician surveys and the clinical scenarios indicate what physicians say they do, but not necessarily what they actually do. So such surveys suffer from recall problems. They also may prompt physicians to think about malpractice liability so that it's in the forefront of their minds when they are checking off reasons for their decisions. Also, these studies can tell us how many and what percentage of physicians say they practice defensive medicine, but generally not to what extent. So clinical scenario studies are considered somewhat better than just direct questions as they focus on a particular scenario or procedure or test, but then because they're so specific, they may be limited in their generalizability. And then lastly, the statistical analyses of the impact of malpractice risk can provide evidence of the impact of differences in malpractice risk on physicians' use of tests or procedures, but they can't provide a comprehensive estimate of the extent of defensive medicine or a baseline of defensive medicine. So such a study, for example, might find that there's a difference in C-section rates between physicians who have been sued and who've not been sued, or between physicians with higher and lower malpractice insurance premium, or between physicians in states with damage caps and states without. But they can't, again, determine the overall baseline amount of defensive medicine that's practiced by physicians. The early studies before 1994 were also limited because often there was not available or good quality data on physician utilization of different tests and procedures. Or if such data was available, it was only available for small groups of physicians who may not have been representative of physicians more broadly in terms of their practice patterns. These studies generally did not control for other relevant factors such as the health status of the patient population. In reviewing these prior studies, OTA found that the results of the direct physician surveys conducted by national, state, and specialty medical societies were highly suspect because they invariably prompted responding physicians to consider malpractice liability as a factor in their practice choices. So they then focused their attention on prior studies with strong research designs, and they initiated several new studies of their own, including hypothetical case scenarios and utilization of healthcare services, or changes in practice based on level of malpractice risk. Selected findings from the OTA report were that physicians are very conscious of the risk of being sued and tend to overestimate that risk. A large number of physicians believe that being sued will adversely affect their professional, financial, and emotional status. Defensive medicine is a real phenomenon that has a discernible influence in certain select clinical scenarios. For example, C-sections and the management of head injuries in emergency rooms. That overall, a small percentage of diagnostic procedures, certainly less than 8%, and this is procedures, not costs, is likely to be caused by conscious concern about malpractice liability. And perhaps most importantly, they concluded that it's impossible to accurately measure the overall level of national cost of defensive medicine, in large part due to limits on the methods of measurement. Regarding their assessment of the impact of tort reforms on the practices of defensive medicine, OTA considered the range of traditional tort reforms that states had implemented up until that time. This is a list of them. I think most of you are probably familiar with most of them, but let me just explain a few that might not be common knowledge. So the collateral source reform. The collateral source rule prohibits the introduction at trial of any evidence that a patient has been compensated or reimbursed for costs that they incurred from an injury from any other source, usually like health insurance or disability insurance. Some states have modified the collateral source rule, either permitting the jury to consider the compensation from other sources that a plaintiff has received, or requiring a mandatory offset against any award for the amount of collateral source payments that received. The other one I wanted to mention is joint and several liability. The joint and several liability rule is one under which each of the defendants in the tort suit can be held liable for the total amount of damages, regardless of his or her individual responsibility. So someone who was maybe only 20% responsible could be liable for 100% of the damages. In states with a joint and several liability rule in medical malpractice cases with more than one defendant, if a hospital is involved, the hospital is usually the party on the hook for the full amount of the damages. The hospital could then turn around and sue the doctors for their share, but I think they rarely, if ever, do this because they may not have physicians who want to practice there. Several states have eliminated the joint and several liability rule for medical malpractice so that hospitals and physicians are only liable for the portion of the injury that they are responsible for. So I think those are the most important ones to understand, and their relevance will become clear as we move forward. The OTA looked at 6 prior studies on the impact of certain tort reforms, the ones that are listed here. And basically what they found, although they found that each of these prior studies had some methodological and data limitations, they concluded that across all of the 6 studies, only caps on damages and amending the collateral source rule consistently reduced one or more indicators of direct malpractice costs. That the effects of other tort reforms may have only modest effects on direct malpractice costs, that the effects on defensive medicine are largely unknown and are likely to be small. To the extent that these reforms do reduce defensive medicine, they do so without differentiating between defensive practices that are medically appropriate and those wasteful, very costly in relation to their benefits. The OTA report was prepared, if you recall, in 1994 was when Congress was debating Clinton health care reform. And healthcare reform would affect the defensive medicine. They just looked to different reimbursement methods and found that the fee-for-service system both empowers and encourages physicians to practice very low-risk medicine, and also that healthcare reform may change the financial incentives towards doing fewer rather than more tests and procedures. So as part of our review of the literature over the last 20 years, we looked for those kinds of studies. And now I'm going to turn it over to Brad, who will talk about them.
Great. Actually, so where is the move? Oh, all right. So great. So thanks, Diane. Thanks, Steve, for having us do this. And also, I guess, thanks to you all for having some interest in the academic-oriented research on defensive medicine. So as Diane said, what I'm going to try and do is take us from the OTA report onward and try and summarize the academic studies that have been done over the past 20 years or so. I'll do that over the next 20 minutes or so, but first let me start off with essentially a summary and give a lot of this credit to the Congressional Budget Office, because what they do as a federal agency is try and synthesize a lot of the economic and policy literature that's out there that's easier for those of us in academics to try and get a handle on things. But one of the roles of CBO is not to, for instance, come up with an estimate of defensive medicine per se, but really to try and analyze the effect of policies on changes in healthcare spending or other outcomes. And so in 2009, they came out with this letter and summarized that a package of tort reforms, that I'll describe a little bit later, is likely to reduce healthcare spending by 0.5%, right? So a little bit on the small side. And that 0.5% is comprised of a small reduction in malpractice premiums, but also a reduction in the practice of defensive medicine. So another kind of big picture takeaway, Michelle Mello and colleagues in a 2010 Health Affairs paper put out an estimate that defensive medicine represents about 2% of all healthcare spending. Both of these papers, both the CBO letter, their prior analyses, the Michelle Mello et al. Health Affairs paper, really rely heavily on this Kessler and McClellan paper and the methodology they set forth in their 1996 Quarterly Journal of Economics, and I'll talk about that. And in doing so, I think what I'll try and do is present this as a bit of a story, right, chronologically in terms of how the literature has evolved and in some sense how the thinking has evolved over time, right? So as Diane mentioned, there's really kind of two main approaches for researchers to try and go about this. The first one is to try and just do these direct qualitative surveys, asking people how much defensive medicine they practice, provide them with some clinical scenarios, and as Diane mentioned, OTA, subsequent analyses, even us, you'd be a little skeptical of what those type of surveys would yield. So alternatively, there's a bunch of statistical or econometric analyses which don't really try to focus on quantifying the total amount of defensive medicine, but really try in some sense look at experiments that have happened, natural experiments that happen, to try and look at the change in defensive medicine as influenced by some change in the environment, right? And in some sense, these are looking at outcomes like spending, utilization, mortality, but one approach is to look at changes in the risk they face, direct risk like the malpractice premiums they face, claims frequency, award size, whereas another approach is to look at changes in tort reform, right? So a state passes a cap or a state changes its joint and several liability, look at what happens in the difference in spending pre and post, but also compare differences from other states that didn't implement those changes and do what we economists often refer to as a differences in differences approach. And again, it's kind of looking at a natural experiment. Okay, so quick again to summarize, the OTA's finding, and this is kind of the thinking between 1994 up to 1996. Relatively small proportion of all diagnostic procedures is likely to be caused by conscious concern about malpractice liability risk. And again, these kind of come from these clinical scenarios. OTA is finding traditional tort reforms, they reduce malpractice insurance premiums, right? So there's pretty broad consensus about that. But the effect on defensive medicine, unclear. Okay. So if that's kind of up to 1996, then Mark McClellan and Daniel Kessler in a 1996 Quarterly Journal of Economics paper, really highly regarded economics paper, documented some defensive medicine. So basically they had a handle on patient-level information in the inpatient setting for the Medicare program, patients with heart disease for 84, 87, and 1990. And essentially what they did is looked at individual level outcomes as a function of changes in the state laws, right? So they looked at both spending but also mortality. And I'll just read their results here. Malpractice reforms that directly reduce provider liability per pressure, again, these are the state laws, lead to reductions of 5 to 9% in medical expenditures without substantial effects on mortality, right? So this is by and large like caps on economic damages. So they also in their abstracts note that there are smaller increases in Medicare spending related to elimination of joint and several liability, and I'll kind of circle back to that in a few minutes. Okay. So for a while, right, so this is 1996 up to 2005, this is kind of like the one careful paper that people are referencing about the presence of defensive medicine, right? The Congressional Budget Office comes along like 2005, 2006, and they're like, well, hey, let's try and use this approach of Kessler and McClellan, but let's extend it, right? So if Kessler and McClellan just looked at heart disease, CBO was like, well, let's look at all spending, right? Because maybe defensive medicine is particularly higher in cardiac treatment, right? So they wanted to extend to all Medicare inpatient spending, but they're also interested in the effect of other spending, right, in the physician outpatient sector. But then on top of it, they were also interested in extending the analyses to not just Medicare spending, but total healthcare spending, including Medicaid and private health insurance, and then also interested in doing a bunch of geeky econometric stuff that only the economists can like, these controls and specification checks. So essentially what they're doing is they're pulling together lots of state-level spending for 1980 through 2003. Again, they've got these different categories for all versus Medicare, total versus inpatient versus physician, running these regressions for state-level spending on the presence of whether states have implemented a series of different reforms. I'll show those in a second. But the main kind of takeaway here was that for the state caps on non-academic damages, they found a 1.4% reduction in overall spending, with those reductions concentrated in the Medicare inpatient setting. And then they also found an actual increase in spending as a result of reforms to modifying joint and several liability. And again, like a lot of people initially were like, this is counterintuitive, but I think I've got a story for you in a second. But first, this busy chart is trying to kind of discern all this down into kind of one easily to interpret manner. So basically, each of these columns going across is a different state law, right? So a state passing a cap on non-academic damages. The second one, a state passing a law to modify or eliminate joint and several liability, and so on. And those are the two ones that have the most action, all right? So what do the H, P, A, and Ds mean, right? So H is basically all spending in the hospital sector, so across all payers, Medicare, Medicaid, private insurance, uninsured, right? All spending indicated by H. P is all spending in the physician, or all payers for physician care. And then A and B are Medicare Parts A and B. Medicare Part A for hospital, Medicare Part B for physician. Okay, so the squares are essentially the point estimate of the change in spending, where the bars are essentially indicating a confidence interval. And so you can kind of see these confidence intervals are kind of high, which led CBO and others to kind of say, well, we think there might be something going on here, but it's really hard to say because there's not much precision, okay? And so again, I think you can kind of see that if there's an effect, it's probably a little bit higher for hospital spending than for physician spending. And when there's effect, it's a little more stronger for Medicare than for other payers. Okay. So now this joint and several liability, and why is there this odd finding that a state passes tort reform and suddenly defensive medicine goes up, right? So the initial thought was like, well, why should it go up, right? This ought to mean that people ought to be less likely to bring forward lawsuits because they're less likely to go after like the hospital for all of the damages, right? And so this is why this is initially counterintuitive. But I think the best explanation that's kind of evolved is that, well, by holding proportionate liability, that gets physicians who previously thought, well, they're going to just sue the hospital because they've got all the money, now being a little bit concerned that the physicians are going to get sued. And so this reform actually triggers perhaps the physicians to provide more defensive medicine, right? So we know this for sure? No, but that's kind of like the economic story behind this. Okay, and then so again, like the main message to policymakers in 2006 here from CBO is that, well, you know, maybe there's an effect. It's probably a little small, but we're not so sure it really exists, largely because of these confidence intervals in the estimates. Okay, so this is kind of the thinking up till 2008, right? So then 2009 comes along, and the CBO sends a follow-on letter to Senator Hatch, Republican Senator Hatch, and I'll just go ahead and read this. Because of mixed evidence about whether tort reform affects the utilization of healthcare services, past analyses by CBO, which we just discussed, have focused on the impact of tort reform on premiums for malpractice insurance. However, more recent research, our emphasis added, has provided additional evidence to suggest that lowering the cost of medical malpractice leads or tends to reduce the use of healthcare services. Right? So again, the big picture here is up to 2009. CBO was saying, probably maybe not so much going on. If it exists, it's small, but we can't really quantify it. And then in 2009, they say, hey, look, some more studies have come out. We now think that there's something actually going on here. And that, in turn, led the Democratic senators, Rockefeller and Braley, to kind of be like, oh, what's going on? And then CBO had to do some follow-on explanations to them. All right. So real quick, what are these three main studies that kind of came out? One was 2007, Baker, Fisher, and Chandra in Health Affairs looked at health spending as a function of malpractice awards and premiums and found a significant relationship. Locke-DeWall and Severity looked at county-level spending as the county-level healthcare spending as a function of jury awards from some data, county-level jury awards from RAND collected. And then Abraham, Daphne, and Schanzenbach had a paper that looked at premiums paid by employers as a function of states passing laws and found that those premiums reduced when states passed these laws. And there was an effect concentrated within HMOs that I'll circle back around in a few minutes when I talk about some implications for Maryland. Okay, so again, big picture, CBO is kind of saying our thinking has evolved in this in 2009. We've got some additional studies. Here they are. Now, what do we expect will happen if there's a federal package of tort reforms? What do we think is going to be the effect on spending? And again, this is like CBO's mission, right, to predict what's going to happen from federal laws, right? So CBO now estimates that, this is them, right, in their letter. CBO now estimates that if a package of proposals was enacted, it would reduce total national health spending by about 0.5%, right? Not 5%, right? 0.5%, right? So it's there, right, but it's small. And so you can ask, well, why is it so small? Well, actually, before that, as I mentioned earlier, this 0.5% is the combination of a reduction in the premiums directly, but then also the follow-on reduction in utilization. And that package was these 6 reforms that you can see here. All right. So now, like, why is this estimate so small? Right? Why is CBO saying that it's so small? Well, first off, if you go back to here, right, these effects of tort reforms on healthcare spending are pretty small, right, in the neighborhood of like, 2, 3, 4, 5%, right? So the effect of any given tort reform on spending is modest, right? But then as a follow-on, right, if federal reform is going to enact a package of health reforms, well, caps actually reduce defensive medicine, presumably, but joint and several liability increases it. So there's a net effect where they kind of wash each other out a little bit. And then the third reason is that, well, many states, if not most states, have already done something on tort reform, so a federal reform is going to come on and pass additional ones. A lot of these federal reforms are just not going to be binding in states that had already passed them. Okay, and actually we'll circle back to what these CBO results imply for Maryland in a few minutes. But I want to make a couple of follow-on comments. The first is that, so CBO's thought on this has evolved a little bit, but the literature is still mixed, right? So a number of other studies that are careful in good journals generally haven't found effects. And so here are 4 really good examples that are careful that haven't found, or maybe a small effect of malpractice risk on defensive medicine. Okay, so now to kind of pivot just slightly and think about what this literature means for Maryland as we transition to a new payment model. I'll start off by quoting something that OTA said in its 1994 report, right? Defensive medicine evolved in the context of a fee-for-service healthcare system in which physicians, for the most part, face little to no financial penalty and sometimes were financially rewarded when they ordered or performed extra tests and procedures, right? So that kind of begs the question, well, like, what might happen if you switch from fee-for-service to something else, right? Well, there's actually a couple of studies that kind of are related, not perfectly related. No one's examining a global budget in some other state, right, because they don't exist. But a couple of papers are related, which we think we can draw inferences from. The first one is Kessler and McClellan in 2002, right? So they had their 1996 Quarterly Journal of Economics paper, kind of set this framework. They published some subsequent analyses afterwards. This 2002 one essentially asks the following question, right? We see this relationship between tort reforms and defensive medicine, right? Well, does this happen like to a greater extent or a lesser extent in areas where managed care penetration is higher or lower? Okay, and what they essentially found is that this relationship between tort reform and defensive medicine was concentrated where managed care penetration was low, right? Arguably, where fee-for-service is like the dominant form of reimbursement, and so managed care comes along and is able to do some of the things to reduce defensive medicine through potential mechanisms, right? Similarly, Abraham's 2012 paper that I discussed a few minutes ago did some follow-up analysis when they were looking at premiums as the effect of the effect of state reforms on premiums, and they found that these effects were concentrated in HMOs and unobserved in PPOs. Okay, so what is this? What can we draw from this to now Maryland's payment model, right? So it's a little hard to say, right, because it's not really clear what exactly the managed care plan is doing to try and reduce defensive medicine, right, in the absence of these caps, right? Is it just a financial payment where under fee-for-service you get money when you do more services, and now switching to capitation or in turn maybe switching to global budgets mean there's that financial incentive? I think that's probably a good story. But there's other possibilities where maybe it's the HMO's utilization review, maybe it's their setting up of narrow networks to only pick the providers that aren't doing defensive medicine. Not really sure. But if it's the payment model, right, if it's the switch from fee-for-service to a fixed payment, then, right, with lots of caveats, then you'd probably conclude that Maryland's shift from a fee-for-service model with no volume constraint, caveated, to this overall global budget ought to reduce defensive medicine in Maryland to the extent that it exists, right? So with that, let me turn it back over to Diane to bring us home.
Okay, so going back to the findings that tort reforms have a relatively minor effect on the practice of defensive medicine, in a 2010 article in the Journal of General Internal Medicine, Hermer and Brody asked, why might defensive medicine be associated with higher costs of care without it being true that tort reform would necessarily reduce those costs? And they speculate that one possibility is that defensive medicine is only one among many causes for unnecessary care. So I'm going to switch gears briefly and talk about other factors that may affect the practice of defensive medicine other than tort reform. So these factors that are that motivate clinical practice decisions, and they operate in tandem with defensive medicine decisions. So, for example, the clinical factors that both affect physician decision-making about whether to order a specific diagnostic test and whether to engage in defensive medicine include patient symptoms, the seriousness of the suspected disease, the degree of certainty about the diagnosis, the accuracy of the available diagnostic tests, and risks and benefits of treatment or no treatment. And what might be considered defensive medicine is more likely to occur when the suspected disease is very serious, for example, some type of cancer, and the physician wants to be very certain of the current diagnosis because the risks and costs of a wrong diagnosis are very high. So then there are other non-clinical factors, aside from potential malpractice liabilities, that also affect the practice of defensive medicine, at least, again, from the literature. These factors have come up based on studies. Most of them, again, these are a list from the OTA report. So one is the availability of technology, another is physician specialty and training, practice organization or practice setting, familiarity with the patient, awareness of and sensitivity to test costs, financial incentives, patient expectations, and the insurance status of the patient. And more recent studies have also looked at some of these factors. For example, in a study by Studdert et al., they found that technology plays a key role in defensive medicine, and that high-risk specialists that they surveyed report using technology to, and I'm quoting now, pacify demanding patients, bolster their own self-confidence, or create a trail of evidence. And that they concluded that defensive use of technology can be self-reinforcing, and that the more physicians order tests or procedures with low predictive values or perform aggressive treatment for low-risk conditions, the more likely such practices are to become the standard of care. So we were also asked to look at whether certain service lines or specialty areas of practice were more likely to incur higher defensive medicine costs. And there are very few studies actually attributing a specific amount of defensive medicine costs to a specific specialty. However, a number of studies, mostly direct physician surveys, have looked at the practice of defensive medicine for specialties at high risk for malpractice. And these specialties have generally included, and there's a lot of consensus in the literature, emergency medicine, obstetrics and gynecology, surgery, including general orthopedic and neurosurgery, and radiology, especially interventionist radiology. These areas of risk, high risk, were generally confirmed when we interviewed people who work at a few of the companies insuring hospitals and physicians in Maryland. One other anecdote from one person we spoke with was that they were seeing an increase in suits against the hospital related to nursing malpractice for such things as bed sores and falls in medication areas, and alarm fatigue, which I guess is when a nurse doesn't respond in a timely manner to a call. So most of the studies, though, on defensive medicine in specialty areas are based on the physician direct surveys and self-reports, which I mentioned earlier may be biased or limited by lack of recall or definitional problems. Specialist studies using regression analyses in suits are somewhat less likely to be done, but the area of specialty where we're most likely to see them are in obstetrics, and where the studies primarily look at the rate of C-sections. So obstetrics has been described in numerous studies as high-risk specialty area, and reasons for that include things like there are 2 patients, not just one. It's not always clear whether the injuries or the disabilities of the child after birth are prenatal or perinatal in origin, so causation is an issue. And if there's injury to the baby, the damages include care for a lifetime. And that physicians and others have asserted that many C-sections are performed defensively, and that the current high rate of C-sections is due to malpractice liability risk. While a number of statistical analyses have found that a higher malpractice claims risk as measured through obstetricians' malpractice premiums or claim frequency is associated with an increased risk of or increased rate of C-sections. There are other studies who have that have not. So the findings are somewhat mixed. So in terms of what could we say about defensive medicine in Maryland, first, there were no specific studies we were able to find of defensive medicine in Maryland. In reviewing the literature, we had attempted also to find whether there were any unique malpractice risk issues in Maryland, or laws or other practices that, in light of the findings that we found from nationally, would make rates of defensive medicine different in Maryland than in other states. So one of the things we tried to look at was frequency and severity of medical malpractice claims in the state, and what the trends have been and how they are comparing with what is happening nationally. Unfortunately, there is not a lot of data out there that we could find on this. Most of this is proprietary data of the insurers that is not published or made available. So we did find from anecdotal reports in our interviews with some insurers in Maryland that they observed a decline in the number of malpractice claims in the last few years. They said that from their data, this was in Maryland as well as nationwide, but that the severity of payouts has been higher, that the value of injuries has gone up in Maryland and nationally and over the last few years, mostly due to long-term care related to catastrophic injuries resulting at birth. to the extent that we could maybe confirm this, we looked at data from the Maryland Healthcare Alternative Dispute Resolution Office. All the claims, malpractice claims in Maryland must be filed with this office. And we did find that from FY11 to FY14, you can see that the number of claims has gone down from 940 to 588. With respect to the severity of claims in Maryland, the National Practitioner Data Bank has some data on this, but they don't have regular, their national annual reports don't include mean payouts by state, but they do for a few years. So from the data points that we were able to get, and I still have some questions out to the National Practitioner Data Bank to attempt to get more data here. But you can see from this chart, from just a few data points from 2003 and 2006, that payouts, the mean payouts in Maryland increased, and as well as nationally, and that Maryland in both years the mean payouts were greater than they were nationally. So, and the other thing that we looked at were tort reforms in Maryland compared to what was done nationally. So in 1986, Maryland implemented a package of tort reforms that included a requirement that for a certificate of merit, at least 90 days, within 90 days of filing a malpractice claim. That legislation also implemented caps on in Maryland for non-economic damages of $350,000 from 1986 to 1994, and then a $500,000 cap thereafter to increase by $15,000 per year. That was subsequently amended to limit the cap to $650,000 between the beginning of 2005 and the end of 2008. Thereafter to increase by $15,000 a year. They also adopted a provision that would allow authorized courts to order periodic payment of future damages. So we also looked at where Maryland was compared to other states with respect to their tort reforms. So although Maryland has one of the highest caps in the country, it is still within a group of 22 states with caps on non-economic damages. As we mentioned earlier, such caps have been shown in studies to reduce medical malpractice costs. This is a chart that we put together from data prepared by Professor Abraham at the University of Texas Law School. It shows how Maryland's tort reforms compare to those of other states. And in addition to caps on damages, it's important to note that Maryland is just one of only 10 states that has not reformed its joint and several liability rule. And as you recall, CBO found that changing the traditional joint and several liability rule to a proportionate share rule was associated with an increase in overall hospital spending per capita. So what can we say about this data, from this data about Maryland? Well, assuming that the CBO findings would apply to Maryland, because Maryland has adopted a cap on non-economic damages and has not changed its joint and several liability rule, Maryland may already have some lower levels of defensive medicine than other states or than the national average. But there are two caveats I would say to this. One is that it assumes that the amount of caps on damages is not relevant. And because the prior studies didn't really look at the level of the caps, they just looked at whether a state had caps or not. So it's possible that because Maryland's cap is significantly higher than for other states, that the cap may not have the same mitigating effect that it was observed to have nationally. Also, the other is that we have some preliminary data from the National Practitioner Data Bank about claims severity in Maryland, that it may be higher, again, than the national average, which is consistent with the reports that payouts are higher in the wealthier states. But we don't know whether that may impact the practice of defensive medicine in Maryland as well, or how much it might influence that. So let me turn it over to Brad now just to finish up and give you our takeaways.
So yeah, and this will just be a couple of minutes, right? So hopefully no one's disappointed that there's really no way to ultimately come up with an estimate of the amount of defensive medicine, right? It's just often not really feasible, right? So that in turn, what researchers have really tried to do is if you can't really quantify the amount of defensive medicine, well, let's just try and look at what affects changes in defensive medicine. And the way you often do that is to look at the effect of tort reforms on changing defensive medicine, right? So we can get relatively nice estimates of these changes, but it's really hard to get an overall estimate of the magnitude. Okay. Well, so what can we say about the changes, right? So relatively small, right? If you look at the CBO analyses from 2006, they would essentially lead you to believe that affecting tort reform has an effect on changing defensive medicine that's probably in the area of about 3% for hospital spending. But this varies across many things, varies across the type of reform, varies on the setting, varies on overall spending versus Medicare and the like. But another thing that we can say, based on the CBO's analysis again, is that a federal package of reforms would likely reduce total health care spending by 0.5%. And right, so again, hopefully I've tried to make this point about, well, there's overall defensive medicine, there's changes in defensive medicine as a result of imposing laws, but then if you focus on changes of federal law, it's even going to be smaller because the federal law would be doing a lot of things that states have already done. Okay. So then if you're interested in, well, what can we say, what can we infer about Maryland specifically, as Diana said, there's really no data in Maryland to show that its physicians are unique in their practice of defensive medicine. But if we're going to try and infer a couple things, we can probably do two, right? One from the CBO analysis showing that caps decrease defensive medicine, but reforms to joint and several liability increase defensive medicine. Again, as Diane says, that would probably imply that Maryland's at a lower point of defensive medicine relative to the rest of the states, right? Because we've imposed a cap, albeit a very high cap, and we haven't imposed joint and several liability reform. Tons of caveats on that one, of course, and then also tons of caveats on the follow-on point, which is if you're thinking about how all-payer reform, moving to a global budget, might impact the practice of defensive medicine, we would probably guess that it would reduce the extent to which defensive medicine occurs. If you really think that these studies that have focused on managed care have achieved these reductions in defensive medicine primarily through the payment models, as opposed to other things that managed care plans have done. So we thank you again for your attention. It's been a fun practice for Diane and me to go through to look at all this literature, and I guess now we're ready for questions. Right?
Yeah. So Diane and Brad, thank you very much. A lot of work went into this. Obviously, as you could tell, this is something that really has not been done, at least here in Maryland on a comprehensive level, trying to pull together the information. So this is the opportunity for questions, and again, from just the work group members. Greg's going to open up. We'll start here with the work group members that are in the room, and then Greg, in the meantime, will open up the lines of the work group members on the webinar. While he's doing that, I have a couple questions that I'd like to understand. Brad, you had talked about, we don't know the magnitude. We're going to hear some different numbers today, and there are numbers, in different types of studies, and we've talked also about some of those studies had different methodologies, so that may impact what the results are. But in the 2009 report, it showed kind of a split in terms of the magnitude of 0.5, whether that's right or wrong. It split it out by about 3/5 and 2/5, say about approximately a half, between the malpractice cost and the cost of procedures. Is that in the studies that you've looked at and the research that you've seen? Is that sort of typical in that the costs are kind of split in that way, or have other studies have shown that it's
mostly in procedures and not so much in malpractice, or malpractice insurance costs?
So that's a great question. I mean, I think the short answer is that the studies aren't really equipped to make that distinction. And so for the most part, what they're doing is looking at some kind of change in the malpractice tort form of environment and looking at either overall premiums or overall spending. And so if it's an overall premium, then you're right. Like, that's going to include both, like, what you could refer to as the direct effect, in that a provider pays a lower malpractice insurance premium, but then the indirect effect of reducing defensive medicine. Most of the studies just look at that overall effect, but then I'm pretty sure the way that CBO tries to kind of disentangle that is that, well, if they know what the overall effect is from maybe these sets of papers, but then from some other sets of papers they know what the change in the malpractice premium ought to be, you can kind of combine this and figure out that this much must have been the premium, so that this much that remains must have been the defensive medicine.
Yeah, for us, at the commission, I think those buckets are something that helps us to understand what the impacts are. Just, for our payment, when we do our payment update every year, we look at the national market basket. And some things are already in there. Some of the malpractice costs may or may not be in there. And Maryland, this is part of the reason why we want to see if Maryland's different, is the national market basket, reflects some of these many costs, and this is obviously one of them. Sure. I have another question about the 8% of the procedures that tend to be, have a higher liability. In the study, did it identify those procedures that fit within the 8%? Like, I'm sure, and I wanted to see if it conflicts with what Diane had said from her anecdotal evidence from conversations. Obviously, we hear about OB and cardiac care. Was there anything else that you could see that fit within that 8%?
So these were, I think, were based on clinical scenarios that have been done, and it's based on physicians' responses to those scenarios. And they were designed to be somewhat sensitive to malpractice liability, and so they were somewhat leading questions. Like I said, you're given a scenario, and then you're asked to check different reasons for whether or not you would do the procedure. And I think that they found actually that, I know they looked at a few things. Head injuries were one of the areas where they were looking at procedures in particular, and obstetrics, I think, were the two that they primarily looked at. So they were high-risk areas as well.
So head injuries, I think, in your later anecdotal study was not in that list, was it? So that's something.
Well, emergency in the
emergency.
They were as a response to head injuries in the emergency.
And I guess I could mention one additional thing. So if you're looking at our draft report, which is again draft, on page 10 we referenced this Baker and Chandra paper in 2005, right? So Kate Baker and Amitabh Chandra in Health Affairs. They did a similar approach of looking at malpractice risk on Medicare spending, but they had access to really, really refined Medicare spending and was able to look at different types of Medicare spending, and specifically most of their findings were kind of inconclusive for a lot of types of Medicare spending, but diagnostics were the ones that really had the significant effect they found. I can't certainly recall the magnitude, but dig up that paper and look into it more carefully.
Yeah, I can also mention there was a slide that we had prepared that we just didn't have time to include, but more recent studies that we looked at in terms of diagnostic tests that physicians often said they do as a result of defensive medicine were a lot of kind of imaging past purposes. One study, a fairly recent study, asked physicians in high-risk specialty areas about the most recent defensive medicine action you had taken, basically order or whatever, and all of it were the top responses were in CAT scans, MRIs, things like that.
Very helpful. Thank you. So at this stage, open it up for a few questions. We'll start in the room with some of the just the work group members, and then we'll go to the webinar and see if we have any questions there. We're limited on time. We want to make sure that we allow the panels to have plenty of time and others to speak. So we'll try to get to as many questions as we can. And introduce yourself before you ask questions.
Thank you. Thank you very much for this thoughtful presentation. My name is Worthy Panich. I'm an emergency physician. I have a couple of brief comments and a question. Are really from the venue and vantage point of an emergency physician. So one point I'd like to make, and we touched upon it, is what is the definition of defensive medicine? And it actually takes me back 20 years to my residency program, where even the education came back that defensive medicine, the way we practice is primarily in the sense of the patient. And there are, at least in the field of emergency medicine, one, not so many options for post-acute who need some sort of semi-urgent follow-up, number one, and a high-risk population where there's disenfranchised people who perhaps are not their best advocates and don't follow up in the way that they should. And so the teaching was always primarily, you have to act in defense of the patient and make sure that you have one chance at the patient to make the correct diagnosis. This is how we talk. And in the 20 years since I've practiced, I will tell you that there is really a void in the reliable follow-up care and preventative care for many of patients we see in the emergency department. And so the teaching is not far from the reality. You know, we do have to defend the patient in a lot of ways. The second point I want to make is back to the head injury. I will tell you from personal experience, and this ties many of your thoughts together. I actually was sued in 2010 for failure to perform a head CT on a patient who sustained a minor hip injury. The patient 2 weeks later was found to have a hemorrhage and had a bad outcome. The case went all the way to court, and it was dismissed in court by the judge, actually, because the case really didn't have merit. Did it affect me financially? No. Did it affect me professionally? I have not since failed to perform a head CT on a patient who has fallen who's on anticoagulation, because I don't need to repeat that experience. And did it affect me emotionally? Interestingly, in ways that we can talk after this. I did not in ways that you would be expect. So the last comment I want to make is actually a question, and that is what didn't get covered in this presentation. Oh, well, wait, I have one more comment before that. The HMO comment regarding why those patients may have lower use of defensive medicine. I would suggest perhaps, and I know this from my own vantage point, is that those patients who are in HMOs, and good ones like Kaiser, we know have the opportunity for good follow-up care. And so knowing that there is a network to absorb what you can't capture the first time is very, very reassuring. It eliminates that first pass mentality. The last question is really, what's an acceptable miss rate? You know, our patients come into the emergency department with the expectation, at least that me and my colleagues believe, is we will never be wrong. And, you know, clearly that's not, you know, it's something that we can beat up to, regardless of how many tests we do. But I think that needs to be addressed, both on the patient expectation side and on the physician community. You know, how many CAT scans do I have to perform to find one head bleed? You know, is it 100? Is it 1,000? And has any of your research looked into that? And what are expectations, you know, in terms of that, and how can that be brought into the fold here?
So I can say a few words about that. I mean, so great points across the board. On this one about, you know, this question of like, yeah, what's the right amount of diagnostics to provide? I guess paraphrasing in this notion of like, you know, put legal aspects of defensive medicine off the table and just focus on we want to do the right thing for your patient. I guess the economics would come into play and say, well, with limited resources, we're going to have to try and make trade-offs about the marginal cost and the marginal benefit of providing these extra services. And within economics, there's a subfield of cost-effectiveness analyses that tries to think about, well, what's the cost of this service, but what's the likelihood of the benefits, the marginal benefits of providing this new service down the road. That literature, sure, yeah.
I completely agree with that, and that is an argument that does not work on a one-to-one patient basis. You have
no doubt, right? Oh yeah. So no doubt about that, right? But in some sense, I guess if you're taking maybe a more macro perspective about like, well, what should the clinical guidelines be, and maybe even set forth by payers in terms of what seems to be affordable, like you could go about those exercises. They're challenging, but I think your follow-on comment makes a great insight in that you can do all these analyses and you can come up with guidelines about what you ought to do and what you shouldn't do from that cost perspective, but then actually thinking about the patient and the provider in that setting, like it can sometimes just kind of fall apart because.
Is there anything in yours that was in the washer that you don't want dried fully, like that white shirt or something like that?
There's someone on the phone. Your line is open, and we will allow you to ask questions in a few minutes. So.
Can I just add? I just wanted to kind of affirm your last point. And when one of the interviews that I did, and basically the person said, you know, that patients expect perfection, and that that's especially true when, you know, institutions have centers of excellence or have #1 programs. And patient expectations are very high. And follow on to the comment about, you know, clinical practice guidelines. The literature, we didn't get into this, but, you know, there is some literature saying that you know, safe harbors for physicians, if to the extent that they follow clinical practice guidelines, may be effective in reducing defensive medicine. But then there's a lot of that literature also indicates that, you know, it's hard to develop those clinical practice guidelines that there's a consensus around that are considered, you know, not biased in some way because they're established by a specialty group. So, I mean, there may be additional things that can be done there to, you know, both say what are the right amount of tests at least, and that would be from some protection for physicians.
Dr. Panich, your question leads me to think that on the Kaiser issue and the support in the community leads me to think we should have invited the care coordination work group as well. I'll run out of space. So, yeah, Mike.
Yes, Mike Robbins with the Maryland Hospital Association. Thank you for a very in-depth study of past studies here, but they seem to have been exclusively studies done within the United States. And it occurs to me that there are a number of other countries that in fact have been working or continue to work under global budgets, not too indifferent than what we've adopted here in Maryland. And I'm wondering if you looked at any of those studies, whether the frequency of claims, whether the frequency of the types of services or procedures that are consistent with defensive medicine occur less frequently, more frequently in those countries that have adopted global budgets. Did you look at any of that kind of research?
So the short answer is no. I think in our limited time to try and devote to this, we figured we'd focus on the U.S. context. But I do think you're exactly right. If you're thinking about the change here in Maryland with global budgets, like abroad is really where similar payment models have been implemented. So I agree. It'd probably be useful to look at those. I think that it's always going to be a challenge to try and translate those findings back over here into the U.S. setting, but certainly
I would
go about
suggest,
that.
just as a general comment, it's probably more translatable than the inference or the relationship you've assumed between managed care and global budgets. The global budget as it's designed is very different than how managed care payments are being made to providers in those settings.
I just wanted to follow up and ask, do you know if any of those, in those countries, they've looked at global budgeting on the impact on defensive medicine? You don't
I
know?
actually don't,
Okay.
but that's why I asked.
Yeah,
Because
okay.
we know that global budgets weren't just adopted for the first time here in Maryland.
Right.
They've been used elsewhere.
Thank you.
From the room, anybody else?
Scott.
Scott in our Calvert Health System. Couple of thoughts that I want to play off of Orly's.
Speak up a little bit.
Sorry. A couple of thoughts I wanted to that were engendered also in line with Dr. Panich's comments. Given the key definitional challenge of defensive medicine between partially, primarily, solely responsible from the perspective of the ordering provider and conscious versus subconscious, it becomes very challenging to determine what's really defensive medicine or not. When you look at the most recent studies, I guess it came out in JAMA in November, you had doctors rating themselves, and ultimately the difference between them was $21 a patient. You know, that tend to be more versus less. And 1.25% on a sample of 3,000 orders is not huge. But what it comes down to, at least from where we sat and what we talked about over last winter and spring and early summer, in terms of making sure that the new test, the value-based test here in Maryland, can work, whether or not we can avoid those issues which are treatment orders that are potentially or not evidence-based, potentially unnecessary, with the challenge that when you have macro rules in the micro environment, it always gets, the doctors will scream at me that you can't do that. That being said, I think there is a physician perception issue. The 2003 study in the Annals of Emergency Medicine found, on the use of antibiotics, found that 75% of the time the doctors were wrong as to whether or not the patients wanted a particular prescription when they were motivated, admittedly, saying what they thought the patients, whether or not they gave antibiotics. I think that there is a real challenge, particularly in hospital-based physicians, ED hospitalists, that don't have a relationship with physicians. We've known for decades that one of the best indicators of whether or not you're going to have students, your bedside manner, your relationship with physicians. If you have a shorter time to establish it, you're going to have more of a risk of not doing it, having that positive relationship. And so has there been any studies or any looking at tying in, rather than the traditional tort reform, let's just cap damages, and I could have a whole discussion over the, given that most of those costs, as you noted, Professor Hoffman, are for long-term care and economic damages. Capping non-economic damages can have no impact on actual long-term care. It's economic damages. But has there been any thought or any studies about providing protections for physicians or providers that follow evidence-based formalized guidelines?
Well, I looked at there have been a few states that have had demonstration projects with respect to the implementation of clinical practice guidelines, and Maine was the one that did it for about 5 years, and they, I think, concluded that it didn't have any effect on malpractice risk or suits. So, and then Maryland in 1993 actually the General Assembly did pass a law that was to there was an entity that was supposed to come up with clinical practice guidelines, but that for some reason never got implemented. So I'm not sure exactly what the story was in Maryland. And I think Florida and maybe one other state also tried to establish clinical practice guidelines and have them used as an affirmative defense. And there's been some constitutional issues regarding that. If you can't also use it, the plaintiff can't also use it to say if you don't comply with it, then that's you're automatically liable. So there have not, based on those demonstration projects, there has not been much data at all, and what has come out, it doesn't seem like it's made a difference. But there's still, in the more, that was a while ago, a decade or so ago. The more recent literature is still kind of promoting some idea that clinical practice guidelines might be helpful.
So here too, maybe an international perspective could help. I think there's two things to say. One is NICE in the UK, right? National Super Clinical Excellence. They set guidelines, so I guess it'd be interesting to see what the legal environment in turn implies, given that they actually set the guidelines for what is and is not covered. And then I guess my understanding is also several countries have kind of moved towards this medical court procedure where, if there's guidelines, have fellow clinicians kind of evaluate what happened.
One of the challenges of looking at internationally is that because they pay for health care so differently, and the bulk of our damages are paying for health care to fix whatever went wrong, you're comparing apples and oranges in the risk environment.
Yeah.
I was also going to comment again on the international, because I'm intrigued by that. And we did pull up some international articles, but they didn't deal with the global budgeting in defensive medicine. But I think that they're in those cases you have to be careful because the tort system is so different, and many of those countries are much less litigious than we are. So.
In the interest of time, let me, yeah.
I do have one question.
Okay, go ahead.
And it really is in terms that you talked about, you indicated under managed care and less defensive medicine, but, and maybe this wasn't your charge, but it seems fundamental to look at Maryland's plan, the new waiver, value-based care. And I've heard it, discussed a lot. Whoever else is here from the health plan work group, I don't see anybody, where all the discussions are high value, low value care, and who's going to value that care? And aren't we making the providers, or did you look at the providers' vulnerability to malpractice suits if these decisions, if there's a new standard of care being developed in the state of Maryland where cost is central to the decision of what quality is? I just want to know how you may have looked at that.
I guess two things to say, and I guess both probably reflect my perspective as an economist, right? So as an economist, we tend to think about these things financially, and so yeah, there's this whole emphasis on value, high value, low value, but I think at least from my perspective and my colleagues in the profession, we're thinking about this financially, right? And how does the payment model in terms of fee-for-service versus something else either incentivize more care or disincentivize more care, right? And so I think that's the perspective at least I've taken in terms of thinking about the managed care papers. The other issue you raise about more of kind of the physician's perspective, as we noted earlier, that kind of comes through from some of these qualitative surveys, but on kind of the more econometric-oriented analyses, what you have really is not the physician's thoughts, but you have their actions in terms of procedures provided and the like, and so that's what we wind up studying as economists and other health services researchers.
I would just say, because there's talk, appropriate, this is appropriate care, this is not appropriate care, and physicians, providers being put in the position of trying to figure out what that is. Are we going to have a clinical standard of care here, and a state value-based standard of care there, and what standard is the provider being held to? So that's a concern that I think, I don't know if you can give more thought to it sometime.
A couple real quick comments. First of all, I mean, I think anybody would tell you that, and CMMI would tell you that it's not cost that drives this thing. If anything, it's quality first. And I know you serve on the payment models work group, but if you're in the performance measurement work group, they'll tell you that absolutely quality is their number one. So I don't want it to be thought that this is all driven by cost. It's absolutely not. The second thing is the points you're making about aligning some of the care, the standards, and so forth are important, and the physician alignment work group is looking into some of those issues on how best to do that. We're also going to be looking in the care coordination work group about care plans. Can we standardize? Does it make sense to standardize care plans, which all kind of feeds into so everybody's kind of reading off the same song sheet. Barry.
Since there are two components to the cost part of it, one is defensive medicine and the other is the cost of malpractice insurance, did you come across any studies that either tried to estimate or concluded what the difference would be if we moved to a no-fault system like the workers' comp system, where in fact you don't have to prove a fault at all? And in other words, all your tort reforms are rather standard tort reforms, but not particularly aggressive tort reforms, like moving to a no-fault system, where it's very similar to the workers' comp system. You don't have to prove your employer was negligent. You just recover if you're injured on the job.
The impact of that kind of reform on the
Cost of malpractice insurance.
Cost of malpractice.
Recognizing that maybe a third of malpractice premiums end up in the hands of injured parties. Most end up in the hands of lawyers and the insurance companies.
Yeah, there again, the things that I came across with respect to, at least we didn't look at workers' comp and how that had changed, cost of insurance, but there are only a few states, again, who have implemented some kind of birth injury compensation fund, and did not come across any studies that looked at the cost of premium fund.
Right, and we didn't ask them to look at what the future should look like, or what we kind of looked at. So what is the lay of the land today, and what are the costs that we think are embedded in the system today, so that we can but it's a really good question for the broader question of, if we wanted to reduce, in the future, is this something that could do that and be effective at doing? Thank you. I only have, for the folks on the phone, maybe 2 questions. Anybody teed up there, Greg?
Yes, they're all available.
Okay, so we'll take 2 questions from the webinar. Anyone? Michelle, do you have a question? And we can't hear you. Yeah, if you may be on mute.
Unmuted.
Okay. So if you do have any questions, you can email me, and I can forward those to Brad and Diane, or try to field them myself, so that we can get those in. So with that, I think we're going to switch gears. Thank you, Diane and Brad, and welcome to the table. And I think what we're going to do now is give an opportunity for some of the field, the stakeholders, the providers that are here to give their perspective. Again, not on tort reform necessarily, where we should go in the future, but what we believe, what you see out there in the industry about defensive medicine. So the first panel, we're going to bring up Carmela Coyle from MHA, Dr. Scott Spire from Mercy Medical Center, and Larry Smith from MedStar Health.
Thank you very much, and thank you to the work group for the opportunity to talk today about an issue that is obviously very important to hospitals, to physicians, to policymakers, and we believe an issue that needs to be very important to the rate-setting commission, and that, of course, is this issue of defensive medicine. The legislature, as was stated earlier, thought it was important and has asked that this work be done taking a look at the impact and implications of defensive medicine on costs. But I want to remind us that the HSCRC's Advisory Council also thought that this was critically important. That Advisory Council offered strong guidance and talked about the dissonance between the cost containment goals that we have in this new waiver in Maryland and our medical malpractice environment. If I could, I've just got a couple of slides to share with you. The first just talks about the broad environment. These are some of the figures that came out in the previous studies that Brad and Diane shared. This is a big deal in terms of money. The national cost of defensive medicine, fear of malpractice litigation, about $46 billion a year. 13% of hospital costs, at least in whole or part, resulting from defensive medicine. And CBO, in their look at this, said, well, if we didn't have it, maybe we could save some $54 billion. That, of course, has been inflated since the time of that CBO study, but it is a significant number. The second point is that in terms of Maryland, we tend to top the list. That is, we ranked 7th in the nation in per capita medical malpractice payouts in 2013, 4th largest increase in those between 12 and 2013, and we are one of 8 states with more than $100 million in payouts in 2013. You'll hear more from Larry Smith as he reminds me, this is National Practitioner Data Bank information, which underreports, which is conservative. But a second point, Maryland's up there on the list. Third piece is some recent data that talks about malpractice fears on the part of physicians. The point here is, as you look by specialty, we have somewhere between 1 in 4 and 1 in 6 physicians who say that they would perform a procedure that may not be medically warranted because of malpractice fears. We heard from the previous presenters, that we have to be concerned methodologically when you ask somebody how real is it. I think we've also just heard from one of the work group members that it really is impactful in a physician's life. But 26% of emergency medicine physicians have said, yeah, did something that I otherwise wouldn't have done, and 10% of total hospital charges in Maryland are emergency department visits. So we are talking about small percentages but real numbers. And the final slide, if we take a very recent study, this was in JAMA, that took a look and said that 13% of hospital costs are judged to be at least partially defensive. For us in Maryland, that would translate into $2 billion of costs that are partially defensive. So for a minute, understanding the challenges in these studies, let's cut that in half. So that's $1 billion. Let's cut it in half again. That's $500 million. These are very important numbers in the realm of the global budget world that we find ourselves in. So if we can leave that slide up just for the rest, and I'll close because I really want you to hear from our colleagues here. Here's why defensive medicine is important. We have implemented this new waiver in Maryland. We are operating under global budgets with a firm spending cap of about 3.5% per person. So these, what appear to be small movements, are really quite significant in the world of 2014. Maybe they weren't in the world of 1994, and we had much larger rates of increase on an annual basis. The key to us being successful in Maryland is going to be all about reducing avoidable utilization. And defensive medicine is a source of avoidable utilization. So, you look at that 1994 Office of Technology Assessment study. They said defensive medicine is very real, but then, of course, we've got all of these challenges in terms of it's really difficult to calculate. But if we have 8% of diagnostic procedures that we may be able to do without, and what was termed in the CBO study, I think, is an insignificant 1.4% reduction in spending. In our world in Maryland, if we could do even half of that, 0.7 of a percentage point, in terms of reducing our spending in a world of a 3.5% cap, these are very important issues for us to address. In the grand scheme of things, it may appear to be washed out. In our world in 2014, real numbers, real opportunity. If I may close, just a couple of thoughts on the report that was presented this morning. It is, and thank you so much for that work, a very thorough review of the literature that's out there and available, and some of the methodological challenges that we face in trying to quantify defensive medicine here in the state of Maryland. My conclusion is that the previous studies aren't very helpful to the task that we have at hand. And so I would disagree in part with some of the report's conclusions, especially as they relate to Maryland, which seem perhaps at least without foundation or maybe could have more explication to allow us to apply them, and would suggest that if this is a study the HSCRC intends to put in the public arena, that we probably remove some of those suggestions. An example, on page 10, the report talks about how difficult it is to understand the impact of tort reforms, and the results are mixed. But then we go on page 15 to talk about implementation of one reform, caps on non-economic damages, as may have reduced defensive medicine in Maryland. But I don't know that we've really dug in as much as we can. Again, this was a literature review, but to understand did it or didn't, you could reverse that statement and it would be equally as true. Similarly, and this point was raised earlier, the use of the example of managed care and the implications of managed care for defensive medicine, and suggesting that that might be, if you will, an inference for what might happen under a global budget in Maryland. We think that is not the case, that a hospital waiver, the hospital global budgets we have here are very different than managed care. The single missing piece there is what we're doing in Maryland focuses on the hospital aspects, not the physician aspects. We don't have physician alignment yet under this first phase of the waiver, and I think as the doctor said here earlier, I think it is quite different in terms of the managed care environment, and at least this first step that we've made in the waiver. So if we're going to draw conclusions about Maryland, I think there is either more work to do, or we should probably hold back on those at this point in time. More important, I think, the report largely answers a different question, and that's because the literature has largely been focused on a different question. The literature has largely been focused on tort reforms, and are they effective? But that's not really our question in Maryland. We can leave that to Annapolis and the legislature and elsewhere. Our question is about defensive medicine and its impact on cost, its impact on use of services, and therefore how much more difficult it makes it for us here in Maryland to live under a global spending cap. Our task is really not about the effectiveness of tort reform, and I say that because the role of the HSCRC is going to be very critical, we believe, moving ahead. But that role is to articulate and measure the problem of defensive medicine. I think the literature review has suggested it's going to be really difficult, and we haven't been very successful doing it in the past, but we think we need to try. And if we take a look at the significant work that the Commission has already put in to the concept of potentially avoidable utilization, this is the sweet spot. This is the focus that we need to have. Defensive medicine is another source of potentially avoidable utilization. And we think that it will be important for the Commission, even if it's difficult, even if we haven't been successful to date, to move ahead to try to identify indicators of defensive medicine, to try to track that trend on an ongoing basis. Because in the absence of doing that, we won't get our arms around places where we may be able to change the environment to help all of us be more successful under this new waiver. So with that, I'd really like you to hear from two folks who are very, very close to this issue, one perspective legal, the other clinical. And the first, Larry, you may want to introduce yourself more. Larry Smith, Vice President for Risk Management for the MedStar Health System.
Thank you very much, and thank you for the opportunity to be here today. And I really enjoyed listening to the presentation on the report. It is an awfully difficult task, I think, to try to understand the connection between all these issues and what impact it has on physicians in their practice in defensive medicine. Let me start with one comment, though, that's a little bit offline, but it relates to some of the data that many of these studies rely upon, and that is what is the cost associated with malpractice in this country. And often the National Practitioner Data Bank data is used for that purpose of understanding what that impact is. I would suggest to you very strongly that that data is very, very understated compared to the real costs associated with malpractice. As you know, it is only those cases that are reported primarily by PAAA companies that insure physicians that get into the National Practitioner Data Bank. Maryland, Hopkins, LifeBridge, MedStar, most healthcare systems have self-insurance programs. Excuse me, and those self-insurance programs actually don't often report the data to the National Practitioner Data Bank, not because we're avoiding the National Practitioner Data Bank, but because we don't fall under their regulations or their requirements. Cases that are settled by MedStar, by way of example, that involve physicians, often those physicians are dropped from those suits before that suit is concluded, and that data then is really about the impact on MedStar. So MedStar, for example, this year, I'm almost embarrassed to say, is going to spend about $100 million on medical malpractice liability for D.C. and Maryland hospitals. That's an awful lot of money that's missing from the data that we're talking about using for the purpose of understanding impact. And the other issue is that when we look at the impact of severity on the systems, physicians carry usually $1 million worth of coverage, so their claims typically are capped at $1 million when they report those to the National Practitioner Data Bank. The $21 million claim that was hit at we got jury verdict at Harbor is an example of what happens when a claim is dealt with by a healthcare organization, and we've seen many of those most recently across the Maryland jurisdictions in PG County as well as in Baltimore City and elsewhere. So I really think that we need to focus on using the right data to understand the problem before we try to find what the solutions might be. By the way, in terms of severity, I know we're here to not talk about tort reform, but I want to say that tort reform is extremely important to the cost issue associated with running hospitals. And in our Baltimore hospitals, I'll just mention that in 2012, we funded those Baltimore hospitals at the level of $20 million for medical malpractice liability. In 2015, it's at $36 million. And that represents the severity of what's occurring in the claims that are being handled across the Baltimore and the Greater Maryland legal system. Severity is a big problem right now in Maryland. Let me talk about defensive medicine. I have no data because I think data is very, very difficult to get on this issue. I have anecdotal data, and I can tell you I've been living with physicians all of my professional practice in many different jurisdictions, and I've dealt with them both individually and also with their specialties. And I think most particularly what I've been impressed with in the last couple of years is MedStar has drawn together clinical specialty groups in emergency medicine, in orthopedics, in neurosurgery, in surgery. What we're finding is that as those groups get called together to talk about clinical practice, oftentimes they're asking me to come in and talk about malpractice so we can focus on where the liability issues are hitting them. That's the wrong discussion to be having regarding what's best for patient care and clinical practice. All my career, I've tried to make physicians more comfortable in doing what is the right thing for their patients, as Dr. Panish said, rather than what's the right thing to do to avoid a malpractice case. But I can't tell you how difficult it is to get their attention to understand that, because this affects them personally. This is a real visceral issue. They're the ones that are named. Their names appear in the suit. They're the ones that go through depositions. They're the ones that have interruption in their practice. So wouldn't it make logical sense that they individually are going to do anything they can to avoid being in that climate? Dr. Panish mentioned never do a patient with a potential head injury without doing a CT before you discharge them. I can tell you that's absolutely in agreement with every single emergency room physician we've got in our clinical practice. They've seen those suits. The data for malpractice claims that involves each of the specialties is really understood by each of the specialties. You can go to any orthopedic surgeon and say, what are the primary claims that come against an orthopedic surgeon, an emergency room doctor, a neurosurgeon? They know what that data is. So what would they do normally? What would anyone do? Try to take actions that is going to potentially avoid that from being something that affects them. So I think it's naive to think that it isn't affecting the way in which physicians practice and what they order. I would suggest a great resource now for us, if we're going to do this work that Camilla was talking about, are these clinical practice groups that have been getting together to understand how we can do practice better. Let's go into those audiences and talk to them about how we can deal with this issue of identify it, quantify it, and then deal with this issue of defensive medicine. I can't say unless there's a systemic change that they see as real, it's going to be we're going to be able to change it. Let me talk about tort reform and defensive medicine. Tort reform has nothing to do with physicians and defensive medicine. That has to do with cost of malpractice, premiums and funding for hospitals and healthcare systems. Physicians have no interest in talking about collateral source, nor do they even understand what it means. What they understand is, will I be sued? And Dr. Panish asked the question, what is the miss rate in the emergency room that's acceptable? In the legal system, it's 0. When I first grew up in the malpractice world, the definition of malpractice legally was deviating from a standard of acceptable practice for the average practitioner operating with the resources available under the circumstances they're presented with. What's the reality now of legal standard? It's perfection. There is nothing short of perfection expected. If there's an adverse outcome, there is a malpractice claim that's potential, and there's a very good likelihood that claim will be settled, or if tried, will be lost. So I think what we need is a systemic change. I think the suggestion that we look at something like the no-fault system, I know it's been talked about. I know we can't address that today. It's not going to happen in the near future. But it really is that kind of court change that's going to make a difference for physicians. If they knew they were protected from being held to a standard that's unreasonable, we might then be able to work with them to back off of some of the issues that they see as private protection for them against malpractice suits. Thank you very much for the opportunity.
Thank you. And from a clinical perspective, Dr. Scott Spear, who is Chief Medical Officer at Mercy Medical Center.
Thanks, Carmela. And thank you to our authors for a very nice review of a very difficult topic, and thank you to Steve and the Commission for letting me be here. I'm going to make just a few comments, and I hope you'll allow us the opportunity to provide some written comments over the coming weeks.
Next slide. And actually, back up one.
That's all right.
So I'm going to echo some of the things that have been said here. As a physician, I can't stress enough the magnitude of the effect that the threat of a lawsuit carries. Some would say my more constructive work in life involves being a practicing psychiatrist, doing about 10 or 15 hours of outpatient practice as well as emergency department coverage. And I've seen professionally a number of physicians who've been sued, and it ranks equal to, or in most cases above, divorce as a life event. And it is not, as Larry was implying and as Barry Rosen implied, I think, it's not the magnitude of the settlement or the finding, but it's the fact that one is vilified normally over a number of years, singled out as the object of an adversarial legal action, charged with negligence that has a greater impact on behavior than we can easily measure.
Next slide.
So just a couple comments about methodology. Our authors stressed very well, I think, the difficulties in researching human motivation, asking physicians if they felt frightened into doing unnecessary procedures is kind of like asking what motivates you to beat your wife. Findings tend to be underestimated. This last point, again, very much echoes what Barry and what Larry said. The review tries to look at the effect on healthcare spending of traditional types of tort reform that decrease payouts. But that misses the point from the physician behavior standpoint. It doesn't help much to get sued and have a horrible several-year and sometimes 10-year process with the claim, but find out that your insurance company paid out only $300,000 instead of $500,000. That's not the point. It would be helpful to look at the effect of non-judicial administrative alternatives such as the birth injury funds that have worked very successfully in Virginia and Florida for over 20 years. The next slide, and I won't talk too much about particularly emergency medicine, but I think the report accurately defines some of the high-risk areas. I think Dr. Panich said things so well in terms of the ED. Let me go to the next slide and mention a little something about obstetrics. The recent practice of utilizing life care plans and the associated huge awards that Larry referred to in the past 3 years has completely changed the landscape in obstetrics. As much as we saw an increase of 20 to over 30% in C-sections over the past 15 to 20 years, what we're seeing now is even different. At Mercy, where we deliver more babies than any other city hospital, our self-insurance costs have more than doubled in the past 3 years. And now we spend 4% of our annual revenues, rather than previously about 2%, on insurance coverage rather than in providing health care. And that has all kinds of ramifications, and one of them is we, like other community hospitals, have to seriously question whether we can continue to provide obstetric services. And that would be a huge access and financial issue in terms of the global budget. As people know, in response to the malpractice pressures in Philadelphia 2 decades ago, community obstetric programs closed and deliveries were pushed to the academic medical centers. If the same thing were to happen in Maryland, costs would grow up tremendously because the academic medical centers, which are geared more towards providing tertiary care, have charges of 40 and 50% higher than community hospitals. And so that would have a very significant effect on the global budget. This next slide, the worsening malpractice climate, which is really a very recent phenomenon over the last couple years. This worsening malpractice climate in Maryland is very apparent on a macro level, and it certainly impacts individual physician decision-making. When physicians come and interview in Maryland, and especially Baltimore, they are very cognizant of our malpractice situation. For the past 2 years, when we have our annual self-insurance trust meeting, our regulators raised the issue of the deteriorating malpractice effect in Maryland and some of the ramifications that are spreading throughout the state. And we have had the experience of not being able to partner with physician groups that practice in Maryland who have ceased activity in Baltimore, because if their group practices in Baltimore, a claim made in another county could be pulled into a Baltimore venue, which is more difficult. It has tremendous financial ramifications. Next slide, and I'll just say briefly, essentially echoing what Carmela and Larry already said. I would beg to differ with the hope that the global budget, although I love it, it would decrease defensive practices. The global budget is on hospitals, and even when physicians are pulled into it, still the threat of suit far outweighs any directive that people like me might be able to give to physicians. And secondly, just the amount of money is involved. We've heard 0.5%, we've heard over 10%. I don't think there's any physician in Maryland who would say that it's only 1%. But even if it's only 1%, when we're talking about constraints of 3.5% a year, 1% is a lot. Boy, I spend all of my time working on things that are geared towards a whole lot less than 1%. Thank you all very much.
Well, thank you. I apologize for butchering your name, Dr. Spear. I know that.
Very good.
So the next panel, and I know all these names, so Pam Casemeyer, Dr. Steve Shakel, and Dr. Peter Curran.
Hello, everyone. I'm PM Kiesmeyer, and I'm a partner in the law firm of Schwartz, Metz & Wise, and we represent a number of interests before the Maryland General Assembly and regulatory agencies. And I have with me today Dr. Peter Curran, who's an internist in cardiology, and in cardiology practices in Montgomery County and is also now going to be affiliated with the VA hospital, who also has the benefit of having practiced in California, and I must admit maybe other jurisdictions, but I know at least California. And I have also with me Dr. Stephen Schenkel, who is the director of the emergency department at Mercy Hospital and also the current president of the Maryland chapter of emergency physicians. I will, in the essence of time, because I know time is moving, I will let them do the talking. They can much more appropriately talk about the impact of these issues on their practice and the practice of medicine generally. I think the one general comment I would make as we sort through all of this, and I would highly endorse all that you heard from the previous panel because I thought it was exceedingly excellent information, so I don't really want to repeat that as well. But I would say on behalf of the physician community, the one, or as their counsel as I listen to this, the one caution in all of this, I think from the physician community side, is not a lack of interest in working collaboratively with the hospitals and others to figure out how to address these issues, but also being exceedingly concerned, and it's why the Commission has the Physician Alignment Committee, that we don't find ourselves in a situation where the pressures become such that there begins to be system dictation down to the physician on how to practice medicine. And I think that that is a significant worry for the physicians because ultimately, as Dr. Panich so well said, it is the individual patient with the individual physician at the time of care, and some of that can be addressed and some of it can't. And it's it makes the physician community exceedingly nervous that there's going to be a system where they are dictated to and aren't able to use their professional training to treat their patients. And with that, I'll let Dr. Curran and Dr. Schenkel make their comments.
I want to thank Pam for inviting me to come today to speak briefly on behalf of MedChi, and really enjoyed the discussion today, and the made me think a little bit that defensive medicine is kind of like trying to define love. We know it's there, but you don't really know how to put a wrap around it. A few weeks ago, I spoke in front of the legislators, a lot of newbies, in a breakfast, and I kind of spoke a little bit, I think that's why I was invited, on the differences in state culture as it relates to medical malpractice. We've discussed a lot about tort and tort reform, and there's all kinds of laws that have been out there, and states do things slightly differently. And it's one article that I read actually from the perspective of an emergency room physician. I'm a cardiologist, internist, did private practice for 8 years before becoming reformed and joining the VA. It was interesting to me that you can have all the laws that you want, and there's still a huge difference in culture between states, and this may be something we want to think about from Maryland's perspective. And the author of this article I read just compared Florida and Minnesota. And Minnesota may be called the nice state by some, but their average annual malpractice premium paid by emergency physicians was $8,500 a year, compared to Florida, which was $79,000 a year. And this author had practiced in various venues, including Chicago and Indiana and finally Texas, and just commented on the huge differences between what people pay. And you would say, well, are the premiums so much higher in Florida because the doctors make more mistakes? And the answer is, of course not. We all were trained similarly and think of ourselves as competent individuals. But when he looked at this further, he found that if you if you had the same premiums in Florida as you did in Minnesota, for 4,000 emergency room physicians in Florida, you would save an average of $70,000 a year per physician, which would add up to a much larger sum of $280 million a year in premiums. And who pays that difference? Well, you do. We all do. Taxpayers do. And one way of looking at it was the difference in spending for Medicare per capita between the two states. And Florida, on this data that was provided, spends a little less than $14,000 per capita, whereas Minnesota was actually less than $7,000 per capita. So, we're talking about United States, but we're just talking about a huge difference in culture. And you could say, well, maybe it's because the laws are different. Well, Florida had some of the most progressive tort reform. Some of that's being peeled back now as it relates to the cap on non-economic damages. You may be aware that their state Supreme Court actually found that to be unconstitutional and is in the process of removing it. But those differences in per capita spending were already in place and continue to exist, just even with that cap and other laws. And the author of the article I was reviewing suggested that some of this culture takes not decades, but maybe even 100 years to change completely state to state. So this might be something that we want to think about even outside the realms of this commission. And what kind of state culture do we want for Maryland that not only protects our patients and compensates them when they are harmed, but it also protects our physicians so that they want to actually stay in Maryland to practice, and is also good for the state and for the state's taxpayer. Thank you very much.
So, excuse me, Steve Schenkel. Here I think as president of Maryland ASAP. I'm also faculty in the surrounding campus and director of the emergency department of Mercy. So hopefully all those conflicting elements come together into one coherent idea. Perhaps as a faculty member, though, I can say thank you for this morning. This has been one of the most fun graduate seminars with real-world application that I can recall. An awesome effort to bring together a disparate and often confusing literature and topic, and compliments to both of you for taking the idea of defensive medicine, which is often phrased in an exceedingly negative manner, and expanding it appropriately to really trying to practice in the realm of uncertainty. That's what clinical medicine is. If we knew all the answers beforehand, this wouldn't be a question. If I knew who had a head bleed before I did a CT scan, there wouldn't be any question. But there is a question. There's always a question. Steve, you asked us to think about specifically how is Maryland unique, and how does this inform, how does this question of defensive medicine and answers to it, how can we inform the HSCRC and the waiver process? And I'm struck as I think about the waiver's effort on population health and the clinical practice of medicine, which has everything to do with the individual in front of me, as several people have commented so well, that these can be in conflict. The classical conflict is one over vaccines. Vaccination, you're best off if everybody else is vaccinated and you are not. We argue a lot about antibiotic therapy. And there are plenty of things that fit in this mix. In the emergency department, it's often the question of hospitalization, the question of the head CT. What has happened in Maryland is an enormous transition in the risk around the uncertainty of these decisions. The financial risk through the waiver has been put very heavily on the hospitals. The clinical risk has been placed very heavily and quietly on the individual clinician and the individual patient making those decisions. That's one way Maryland is different, and on account of the waiver. I don't know if Maryland is different or not in terms of real risk versus perceived risk. Several people have spoken eloquently, though, that litigation and defensive medicine more broadly has everything to do with both the real risk and then the perceived risk of the lawsuit, of someone coming to the clinician and saying, remember that patient you saw yesterday, because that's scary and that is both real and perceived. What does that mean for Maryland and the waiver? I had three thoughts. One is the challenge of addressing both the real risk in addition to the perceived risk. In terms of tort in particular, one of the things I was actually delighted to see in the report, we need to protect what we have. There's both a concept of doing more, which is grand. We also clearly have some things that do have a benefit in terms of the waiver and cost, particularly our current cap that you mentioned, and not making the changes that 40 other states have done. We need to protect those and then think further. The second idea, and this is an emergency medicine focus with regards to the waiver on HSCRC efforts. Maryland's traditionally different in a Maryland tradition of pushing for access across our entire state. We need to continue that. Dr. Panich spoke eloquently to the head CT. For many in the emergency department, the challenge is, where is this person going to go tomorrow? And when the answer is nowhere, that means I have to do everything today. And we have pursued access in the past, and we need to continue to pursue access. And that is one way of working towards cost and providing better care. The third thought may be outside the bounds of what we've discussed so far, and I apologize for that. Approximately a third of the patients in our department, quarter to a third, are also seen by physician assistants. All of the literature has been about physician decision-making. Part of our expansion of access in emergency care, in primary care, in other areas has been the use of non-physician clinicians. And we haven't even begun, from the perspective of the literature, as far as I can tell, to think about where that fits. And perhaps we need to. So thank you for the opportunity of speaking. Again, this has been just a tremendous morning, so with appreciation.
Oh, sorry, we don't have continuing education credit. I might be able to work that out. We got parking. Anyway, that's great. Thank you very much. Both the panels have been excellent. We have one more that's signed up. And so I don't put any more names. I'm going to have Dan Shattuck introduce your panel right now.
Good morning. My name is Dan Shattuck. I'm here today with Dr. Amar Sethi. I'm going to be very brief because he actually has to head off to work. We were also joined earlier by Dr. Carl Dean, an otolaryngologist, but he had to head out and handle some cases as well. So I'll say something after Dr. Sethi speaks. But Dr. Sethi is an anesthesiologist, and he is the president of the Maryland Society of Anesthesiologists, and has a lot of good thoughts and perspective on this issue.
Yep. I actually work at Good Samaritan Hospital up in Northeast Baltimore, and I'm supposed to be there at noon. So I'll stick to my prepared comments here and try to be brief. We applaud the HSCRC and the Maryland legislature for studying the costs of liability risk in the context of the new waiver. By focusing on the triple aim, coordinated care, evidence-based care, a reduction in redundant services, and capitated budgets, the new waiver will raise the risk of malpractice for individual practitioners as well as healthcare institutions. We appreciate the work done by the Commission on Defensive Medicine. A key quote from the conclusion: despite the relatively large body of literature examining the practice of defensive medicine, there are simply no reliable estimates of the baseline cost of defensive medicine to the healthcare system. That's a key statement from the entire presentation. Truth is that the defensive practice of medicine is ingrained in the basic practice of medicine to the point that the community standard of care incorporates defensive practice. Nevertheless, we as a group must go beyond a simple debate on defensive medicine. The new waiver will shift to accountable care and introduce completely new dynamics that cannot be understood simply by a lengthy analysis of the past. Simply put, we're in the midst of one of the biggest transfers of risk from the government and third-party payers to health care providers and institutions. From a plaintiff's point of view, any discussions of cost reductions and evidence-based practice carry the inherent risk of denial of care. In other words, the best, quote, value of care for a population of people will not always be the best option for an individual. For example, an MRI is clearly not the best first-line test for back pain. Nevertheless, there are individuals in which an MRI is the best test because it diagnosed a malignant tumor or worse. In these cases, a delay in diagnosis could have been catastrophic had a guideline been followed. At least that's what a plaintiff's attorney would say, and that's the perception of the
of the situation. The additional risk would extend not only to an individual physician, but also to the institution that suggests a specific guideline. An example by Glenn Cohen of Harvard Law School in a JAM editorial from 2013 illustrates further. If a poor outcome occurs in a patient with CHF, the patient can challenge an ACO's more stringent CHF and hospital admissions criteria, asserting a prioritization of cost savings over patient care. It's simply too optimistic to hope that improved outcomes from evidence-based practice and coordinated care will necessarily reduce malpractice, either in the short term or long term. We must be careful to separate the costs of defensive medicine and the controversy about it from the risk of liability in the context of the waiver. Regardless of your position on the existing practice of defensive medicine, the risk of medical care within an accountable care system raises unique liability risks that must be understood, paid for, and shared. While these risks are obvious, few studies have looked specifically at malpractice and accountable care. We know that ERISA protections extended to MCOs in the 1990s do not extend to waiver institutions or probably the Maryland waiver. The implications of this are critical and must be understood in a context, particularly in the context of expanded use of physician extenders. The state of Maryland will soon ask its healthcare providers to join together to share responsibility for providing coordinated care to patients. We will agree to be held accountable for the cost and quality of healthcare delivered to a defined population of patients, but we need to address the increased liability risks that follow. Thank you for your time.
The only thing I'd like to add is, and I'm echoing some earlier comments, but this has been a good forum, but hopefully this isn't the only discussion. And I know the focus was on defensive medicine, but I think it's been raised today. There's a lot of surrounding issues. It's a big apple to bite from. And as we look at liability and accountability as the waiver is implemented and further developed, I think this discussion needs to continue in some fashion and not let today be the end. That's all I'd say.
Point taken. And as Carmela said earlier, it is in the advisory council report that the Commission be involved with the stakeholders, understanding the issue. So we will continue to do that, and we look forward to keeping up to date from your perspective. I'd like to thank again Brad and Diane for all the work they've done. It's kind of given us some things to think about and some things to share with our commissioners, as well as the comments that you made today. We are about 25 minutes over our time, but I think it's good. It's all been good 25 extra minutes. Does anybody, just for the end here, for the good of the order, does anyone have any comments, final comments that they'd like to make at this time, either on the phone or in the room? All right. Well, great. Thank you all very much, and we'll see you at some of your future work group meetings.